Caleb, the patient says, I either have a snake in my vagina or I'm having a baby. When you're working in an emergency department with no OB backup, which one are you hoping for?
Snake all day, baby. Snake all
Same.
day.
100%.
When
Same.
you're in a rural area with no backup, you're on an island. That makes you a island dog. Oh yeah, you an island dog. You gonna make it to the top. Oh yeah, you island dog. You got no backup, yeah. You on an island, yeah. You is the island dog. You on the block for real.
So, Caleb, you are a critical care physician. You work a lot in the ICU, but I know at your core, you're truly an EM physician, correct?
That's right. I'm EM through and through. Did a emergency medicine residency and then completed a critical care fellowship and still practice both.
And I know in the past you've worked in a lot of really rural shops, and you still work some at some freestanding and some rural emergency departments. And you've got a case you told me of working in a rural emergency department, and one of the things that I'm terrified of, patient comes in active labor. So set the stage for us. Tell us how that started.
So I'm working in a rural standalone emergency department. We are attached to an EMS station, and this is about a 6 to 8 bed emergency department. This was a weekday in the afternoon, and it was fairly busy as we were kind of hitting the people coming in, toward the end of the workday. And my registration person came up to me and said, we just had someone check in who says that she's having a baby, actively in labor. And the thing that kind of crushed my spirit the most was when she said, and she told me her last baby was born on an ambulance.
Oh, and you were like, "Are you sure it's not a snake? Could there just be a snake there, maybe?"
Yes. I was praying for snake. Unfortunately, this time I was not able to dodge delivering a baby in the standalone emergency department. I still, so my first thought was to still try, right? If it's not active labor, perhaps there's a chance to get her somewhere that's a little, safer for her and for baby than being in a standalone emergency department. So the first thing I did was rushed her back to a room and proceeded to do a quick check to see if we're truly at that active stage of labor.
Yeah, I know you get the EMS station right there. And so all of our thoughts when we're in that situation is, can I get this patient out of here? Can I get them somewhere else? And
yeah, I think I said something along the lines of, get me some gloves and get the truck ready.
Warm it up, baby. Let's go. And so I take it you weren't transferring.
No, I proceeded to do the check, and I was able to feel a full head of hair, and that pretty much sealed the deal that this was not going to be someone I could put on the back of an ambulance and send 40 minutes down the road.
Yeah, and that's part of EMTALA. The L in EMTALA is labor. You do not transfer a patient in active labor. So,
and you're responsible for that patient if you do send that patient until they reach the other facility. So anything that happens en route, and if and when that baby was born again on the back of an ambulance, which would have been her second, then that's still my responsibility. Until both patients at that point arrive at the other hospital. So yeah, it was a big decision and a hard decision, but it was at the end of the day also easy at that point. Okay, we're doing this.
So you feel head, you feel hair, I'm about to deliver a baby, but you've got a few minutes. What's your setup? What are some things that you're getting together?
So just like every other patient, it's IVO2 monitor. So I needed to have access on mom. If we run into any complications, if I need to administer medication or at least analgesics quickly, I need her on the monitor to make sure that she's doing okay. I sent someone to go get the to dust off the warmer, for the baby after delivery that was parked in the corner and hadn't been touched probably in 3 or 4 years. And then also my pediatric airway box, because I don't know, if there's going to be now 2 critically ill patients in front of me. So I had to be prepared for anything that could go wrong with baby once we deliver. So the things that I would like to have, things to monitor fetal heart tones, to time contractions, I don't have any of that available. So, thankfully, like I said, we do have an EMS station attached to the standalone emergency department. So I had a couple of the paramedics come over. I used the Doppler that we use to find fetal pulses. And once I found fetal heart tones, I handed that off to her and said, hold this right here, don't move. And then the other paramedic had a stopwatch, and he was able to time contractions for us. So that was the setup.
Nice. You got fetal monitoring. I love it. And you got your Toco,
Yeah,
the stopwatch.
We're good to
It
go.
works out. So you've got everything set up. You've got all your equipment ready. You are ready to have a baby. How'd it go? How'd the delivery go?
Thankfully, this was a straightforward delivery. This was, I believe, this lady's third, and so it was not a prolonged labor. I think after it felt like an eternity, but maybe 10 or 15 minutes max, we were able to perform a uncomplicated delivery. Baby was doing fine, no issues there. And, in the meantime, I had basically called in the National Guard. I said, call everybody. I don't care. Just get me people here to take these people away once this delivery is completed. We did have to send mom and baby separately, but thankfully they were both healthy and doing well. And once they got to the hospital, I know they were able to put them back in the same room at that time, but we got everybody transported and it was uneventful.
Most babies, could pretty much deliver themselves. And fortunately, that one went that way. But, as EM physicians, we always think about worst first. Some of the complications that can arise. I think one of the most scary is you're delivering and the shoulder gets stuck. You have a shoulder dystocia. I know you probably played that through in your mind and were prepared for that. What's your go-to when you're delivering the baby and the baby gets stuck?
So I think the biggest thing is positioning. So getting those the mother's knees all the way up to her chest, and then in addition to that, if you add some suprapubic pressure, and it's this isn't like a gentle fundal massage. This is really using a lot of pressure to try to clear that that pelvic outlet. So pushing down hard, and it's also suprapubic. It's not at the fundus. You don't want to be pushing up there. That's not going to help us at all. That's my go-to. There's also the help mnemonic, which is really helpful to fall back on. So the H stands for get help. You need everybody you can in the room, which we had already accomplished at this point. E is for evacuate the bladder. That's something I didn't think about at the time and thankfully wasn't an issue. But if you've got a full bladder and you run into issues where you're trying to do suprapubic pressure, you have a shoulder dystocia, you need that extra room to help perform maneuvers. The E could also stand for an episiotomy if it comes to that point and you need extra room for those maneuvers as well. The L is to get those legs tucked in behind the knees up to the chest. And the P is for pressure, again, suprapubic pressure to help facilitate opening that pelvic outlet and delivering the baby.
So this is a great case. It's something we all have to prepare for. Every EM physician on any shift, we could be delivering a baby. From this case, what are your big take homes? What are the things that we should all remember?
I think just staying calm, getting help early, realizing that you need to do that quick check and make a decision immediately. Is this someone who is stable to transport to a bigger center? Because we always want to do whatever is best for the patient. And especially in a situation where you may have two patients to deal with, if you can get them somewhere with more resources, that's the right thing to do. But with EMTALA, if they're in that active stage of labor, we really can't transport them. And you're actually exposing both patients to a lot of risk by putting them on the back of a truck and trying to drive them, in this case, 30, 40 minutes down the road to another center. I think another thing to keep in mind is to get all hands on deck, not just your nursing staff, but in this case, I was super fortunate to have some paramedics, so 2 extra resources available, and everybody really pitched in to make sure that this went as smoothly as possible.
Caleb, great case. It was a pleasure as always.
Likewise. Thanks for having me.
All right, man. Let's do it again soon.